Thank you, Tom, Jose, Jason, and Lou for that important discussion. In our session 4, we hope to engage participants in a dynamic exchange regarding how to choose and validate novel clinical outcome assessments. Though I know most of you know these definitions, to level set our discussion, the FDA defines a clinical outcome assessment, or COA, as an instrument used to describe or reflect how a person feels, functions, or survives, and can be reported by a healthcare provider, a patient, a non-clinical observer, or through performance of an activity or task. There are, therefore, 4 types of COAs: patient-reported outcomes, clinician-reported outcomes, observer-reported outcomes, and performance outcomes. As I noted in my opening remarks for this virtual workshop, it is critical that we seek the perspectives of people with diabetes and DRD and find ways to better understand the social, emotional, and functional impacts. Listening to patients and understanding how their lives are changed by diabetes and DRD, their fears of vision loss, their treatment preferences and concerns, as well as uncovering the individual subtleties of functional impairment and trade-offs with treatment effects is essential to research success, new treatment adoption, and delivery of improved outcomes. In order to set the stage for our discussion on COAs, our Session 4 presenters, Olivia Meyerhoffer and Amanda Bicket, will share findings from data they have generated regarding patient priorities and concerns and through observation of performance of a well-defined task, respectively. Olivia will start us off. She is a global value lead at Boehringer-Ingelheim, where her focus within the eye health organization is on diabetic retinopathy, with the ultimate goal of driving the development and commercialization of innovative treatments. Her areas of emphasis include documenting unmet needs, assessing the treatment landscape across geographies, and capturing the patient voice regarding their experience, journey, and pain points to gain greater understanding on how to best address their needs. In her presentation, Olivia will share some of the key insights collected through her recent market research highlighting current treatment patterns and perceived symptoms by disease stage, and priorities and concerns from patients with diabetic retinopathy. Olivia?
Thank you, Dr. Levine. It's a pleasure for me to be with you today and to share with you the results of this international market research on diabetic retinopathy, where we try to uncover what are the current treatment patterns across several geographies, how patient symptoms present, and what are the priorities and concerns from this patient population. So let's dig into the data, the study objective and the methodology. It was done in 2 parts. Part 1 was surveying healthcare professionals, so treating physicians, that actually manage diabetic retinopathy. There are 2 parts to this first section, a qualitative part with long interviews and a quantitative part with a bigger number of retinal specialists surveyed through online methodology. And then part 2 was a patient qualitative research where we try to understand patient perceptions and their understanding of diabetic retinopathy, as well as the challenges that they face. So let's start with part 1 and a bit more on the methodology of the research. So as mentioned, there are 2 parts to it. The qualitative part was with 79 physicians across 5 different markets with interviews between 75 and 90 minutes, qualitative interviews. And then the quantitative section of the survey was an online survey of 40 minutes for physicians to fill, as well as 4 patient record forms that they had to document, which is a total of 1,300 patient record form documented. And of course, all these physicians had to be treating physicians with a minimum number of DR patients per month and personally responsible for the care of these patients. And we had several research objectives. How do they manage those patients? What is the visual impairment of this patient population? And what are the remaining unmet medical needs based on physicians' inputs? So starting with the unmet needs that physicians expressed, the top unmet needs, of course, relate to improved iteration of existing treatments. So, of course, they would want to see treatment that lasts longer or that are less invasive, so different routes of administration. But among the top 10 that you see here, you see the need for treatment that would have an ability to really stop the progression of the disease, and innovation that would be more suitable for patients that don't have complications of the eye, but would benefit from a proactive treatment approach. And that would be, of course, also an alternative to laser for many of those patients that get PRP laser and that don't have DME. Interesting two quotes here from physicians that really convey the feel for this healthcare professional. The first quote is, "Today we are waiting for disaster to strike." And the second one, "We are limited in what we can do. We cannot affect prognosis." So it tells you a lot in terms of how physicians feel and what remains to be addressed and the level of unmet need in this patient population. Now, looking at how they handle their patient population in moderate NPDR patient without complication, the standard of care remains watch and wait, so no treatment because there are no good options today for this patient population. So still very much reactive and observing this patient population until something appropriate comes along to treat these patients. And then this is for moderate NPDR patients. For severe NPDR patients, you see in the US and in the UK, again, watch and wait being more standard of care for now. And in other countries like Germany, Japan, and China, PRP laser is used in a significant portion of the population to prevent further vision-threatening complications. So not a lot of options for these physicians to choose from, really. Now we've asked them also to look at patient records form again, as mentioned earlier. So on the left side, you see the kind of symptoms that patients experience and that they report. And interestingly, even moderate patients report symptoms related to reading difficulties, contrast sensitivity issues, visual field deficits that are already impacting their quality of life. And it's also even stronger in severe NPDR patients. This is an interesting finding because there is a general perception that this patient population could be asymptomatic because their visual acuity is not impacted, yet you can see already that other elements of vision are already impacted. In addition to that, I want to wrap this first section up with the healthcare professional survey. And the key message are really that watch and wait remains the standard of care for this patient population, even in more advanced stages of the disease when there is no complication. There are very limited treatment options today for these patients. Sometimes laser is used, but anti-VEGF is used in a very limited number of cases when there is no edema. And then, interestingly, patients, even already at moderate and severe stages, do report already some visual impairments, which is going to be further documented by the protocol AR. We are really looking forward to this work. Now, moving to the patient section of this research. So this was more a qualitative analysis where we interviewed 17 patients with 60 minutes interviews, and they also had some homework to perform. Patients were selected from a spectrum of the disease, from moderate stages all the way to proliferative stages. And we try to understand what they know about their disease, how they felt, and what were the key pain points. So all in all, it's interesting to see that they know about their disease, but not a lot. They just know it's a consequence of their diabetes and that is progressive. That's really it. The next element that comes up is the fact that they are aware that there are treatment options, that they are invasive and unpleasant, and they all experience symptoms. So even these earlier patients that we described also reported some symptoms back, which they need to manage together with their other comorbidities. They all live in a climate of fear and anxiety, the long-term fear of vision loss and the short-term fear of invasive treatment. And interestingly, they were all willing to accept preventative treatment should that prevent further vision loss, which is not always what the scientific community would think, that they might not be very willing to undergo a preventative treatment. But apparently, if they understand what's at stake, they would definitely be happy to do so. Now, what's still very much unclear to them is how the disease progresses. So this is not always discussed. And ultimately, they don't understand the specificities of the progression, the timing, which adds, of course, to the uncertainty in how they feel. And they do understand that managing their diabetes could help limit the progression of their diabetic retinopathy. But yet they are still absolutely unsure what timeline we are talking about here. So limited education and awareness on that. Moving on to what other barriers exist. So they generally lack the understanding, as mentioned, of how and when the disease will progress. They think that the current treatment could definitely address their disease progression, so they're counting on that. And then there is the element of present bias that is very strong here, which is the bias of the fear of what could happen immediately to them. So invasive treatment versus the fear of what's more distant, which is the fear of losing vision. And all of that adds up to a limited urgency to act and really be empowered in managing their disease. All in all, it's fair to say that they would be willing to accept an IVT preventative treatment, but that will, of course, depend on the physician's ability to really communicate the benefits of preventing disease progression. So to summarize this last section on the patient survey, this patient really live in fear and anxiety regardless of the stage of their disease. They don't know how, they don't know when, they don't know how quickly it will progress, but they understand that the disease is definitely challenging their quality of life and creating this uncertainty. They all have symptoms, apparently, even at earlier stages. And in general, they are happy with the idea of preventing further vision loss with the support of their physician, of course, with the right level of education. So that concludes my presentation. And now back to you, Dr. Levine.
Thank you, Olivia. Our next presenter is Dr. Amanda Bicket. Amanda is an ophthalmologist on the faculty of the University of Michigan's Kellogg Eye Center, where she directs the Glaucoma Fellowship. Her research centers on patient experiences and functional outcomes of chronic eye disease and its treatments. She holds a joint appointment in the Department of Biomedical Engineering, and most recently has turned her focus to studies of gait and mobility in visual impairment using wearable sensors. In her talk today, Amanda will discuss the power and promise of gait as a patient-derived performance outcome endpoint, learnings from her gait research in glaucoma patients, and her currently enrolling study of gait in diabetic retinal disease. Amanda?
Thank you, Dr. Levine. You've heard today from an incredible lineup of distinguished speakers about structural, cellular, and molecular approaches to measuring outcomes in diabetic retinal disease, and about sophisticated functional testing. Olivia's great talk reminds us that the patients often experience impairment from their diabetes-related eye disease in the mundane essentials of daily life. What if we could follow them into their daily lives to see the impact of DRD and its treatments? I hope to convince you that we can, and we should. First, the why. I think we can agree that a core aspect of the clinical benefit of any therapy is its impact on a patient's daily function. But daily function can be difficult to quantify. Sometimes we use surveys, otherwise known as patient-reported outcome measures, but these can be susceptible to subjective bias. And while they can be highly reproducible, in-clinic or in-laboratory measurements do not assess function in daily life. Wearable devices that can function within but also leave the lab or clinic are able to directly measure things like sleep, levels of physical activity, and walking. In other words, they allow us to collect data directly on how patients function in their daily lives. And of course, when we talk about endpoints, we're talking about trials. So an important driver of this approach is its acceptability to regulators. This published FDA guidance, which is now more than 8 years old, spells out why endpoints proving functional benefit are critical, using the example of Alzheimer's disease, in which the endpoint of cognition can be most meaningfully understood in the context of a clinically interpretable measure of function, like a validated assessment of activities of daily life. There's also peer pressure. In other fields of medicine, use of wearables to generate patient-derived outcome data has been on the rise for a decade. Though the majority of these outcomes are still considered exploratory endpoints by clinical trialists. So we want to measure patient-derived endpoints in a way that reflects real-world daily function in patients with diabetic retinal disease. Why measure gait? In part because we already know it's important. Walking speed has been called by some the sixth vital sign. To justify that designation, I'd like to share this figure. It's from a review article that was published 10 years ago, but it brings together a decade of functional research, and its findings are striking. The average walking speed of those who can safely cross the street independently highlights the mobility challenges that we all face in daily life, and the fact that losing the ability to carry your groceries or do light yard work may be associated with cognitive decline in the next 5 years is fascinating. Gait is not only important, it is complex, and it's thus rich in nuanced information. This image from my collaborator, Laura Ojeda, shows what traces from a wearable inertial measurement unit, or IMU, on the dorsal surface of the foot might look like, and how these can be used to recreate the motion of that foot. We can look not only at pace, but at symmetry or smoothness, and at variability of gait. And we can capture gait with wearables in just about any environment, in a gait garden, in a virtual reality environment, as you heard described earlier, or even in the wilds of a patient's home environment. Finally, and of paramount importance to this group, gait is impacted by eye disease in characteristic ways. I'm a glaucoma specialist by training, so my interest in gait started with an interest in the ways eye disease affected my patients' mobility. Data from the National Health and Nutrition Examination Survey showed that increasing visual field loss was associated with reduced physical activity. And in our own work, we've shown that glaucoma patients for whom loss of contrast sensitivity is an important, if often undermeasured, disease feature, not only walk differently, but cannot adapt their walking to changes in the visual environment, like lighting. Here, I've highlighted a pattern that we saw across both pace metrics and variability metrics. Glaucoma patients showed not only more cautious and variable gait overall, but got slower and more variable in dim light, and more interestingly, did not recover their baseline gait when the lights came back on. Crucially, these changes were evident across the whole spectrum of disease, visual severity, field loss, which is to say from the earliest minimally symptomatic stages of glaucoma. I actually stopped turning off the lights in my exam room for most patients when I saw these results. So now back to diabetic retinal disease. Working from the assumption that microvascular and neurodegenerative changes reduce contrast sensitivity and impact visual field even before diabetic retinal disease is clinically evident, we can expect that gait is impacted by diabetic retinal disease. One of the Mary Tyler Moore Vision Initiative working groups identified visual function tests that might serve as biomarkers in diabetic retinal disease, and importantly noted that both visual acuity in low luminance and contrast sensitivity suggest risk of impairment, and that both contrast sensitivity and visual field are prognostic measures in this patient group. I think we can measure the sixth vital sign, gait, to take advantage of this. First, though, we should mention that we expect gait data in diabetic retinal disease to be influenced by the complex ways diabetes affects the nervous system. In those with diabetic retinal disease, in addition to loss of visual field and contrast sensitivity, diabetic peripheral neuropathy may lead to altered biomechanics and poor sensory feedback, and diabetic autonomic neuropathy may impair balance and increase risk of falls. But while this may make it more complex, it also makes it all the more important to understand the multifactorial motor impairment that comes with diabetes. To begin untangling gait in diabetic retinal disease, we're conducting a study similar to the one I described in glaucoma in patients in a cohort with diabetes. examining gait responses to changing lighting conditions while controlling for diabetic peripheral neuropathy. Since I shared these plans at the November symposium, our team has been fortunate to be awarded funding from the Michigan Diabetes Research Center. Participant enrollment for this study began last month. Finally, to bring us back to our goal of capturing gait endpoints in the real world, I want to share a few figures from our recently completed study comparing in-clinic and real-world gait quality in older adults with glaucoma. This work was completed in collaboration with the University of Pittsburgh and funded by the NIA's Older Americans Independence Centers. We first captured gait metrics in clinic, then trained patients to put on and take off IMUs at home. Over 3 days, they captured 24 hours of free walking data. Among our findings was the fact that the length and speed of steps taken at home and in clinic were clearly associated, but the variability of at-home gait was not associated with in-clinic variability and was often greater, suggesting that testing in clinic may miss the influence of environmental factors on gait. We included in our study of glaucoma patients a patient-reported outcome measure, the Glaucoma Activity Limitation Questionnaire, to explore whether and how patients' self-reported impairment related to changes in their gait. Interestingly, patients with slower gait speeds and more temporal variability in their gait seemed aware of functional limitations, but those with less symmetric or spatially variable gait did not. These results lend weight to the idea that patient-reported outcome measures cannot tell the whole story of real-world function. We have to find ways to join patients in the real world. Again, I'm a clinician, so I want to pursue real-world gait assessment because it may help me and my colleagues guide our patients toward their most functional, independent, fulfilling lives, and because they may help us find clinically meaningful impairment in function even before vision metrics in diabetic retinal disease change. But we are here today to discuss the even broader potential for gait assessment to inform clinical trials. Regulators tell us a primary endpoint for determining that a drug is effective should encompass important features of a disorder and should be clinically meaningful. The structural, cellular, molecular, and even functional endpoints you've heard about today can certainly accomplish the former. Real-world gait endpoints may help us succeed in proving the latter. We'll answer questions in the live session. Now I'll turn it back over to Dr. Levine.
Thank you, Amanda. Let's now shift to our discussion and Q&A.